and welcome to this next session, which is our practitioners panel. We thought the theory is nice, and there's no such thing, nothing so practical as a good theory. We all know that, and so on. But at the end of all of this, most of you, those of you who don't go on and do PhDs and research and so on, you're going to want a job, presumably, if you don't already have one. And so we thought we would talk a bit about where your career in public health can take you and how you got there. And to do that, we've brought together a panel of 4 speakers. Only one, well, in a sense, none of them exactly have a classical training in public health. So you already have a jump start on all of them, because none of them have an MPH. And they come out of very different backgrounds, and yet they all have created very interesting and important careers in public health. And so this is a chance for you to hear their stories. How did they get where they are? Where did they start? What did they do? A bit of that. So they're going to talk about 10 minutes each. If they already know this, if they ramble on too long, I'll stand up. But they're not going to do that, because they're all very accomplished people. And then we're just going to throw it open to you folks for discussion for as long as it lasts, or until 3:30, whichever comes first. So if you run out of questions at 3:15, we'll close it down. Now, we are going to use microphones, not so much because of reaching you folks in the room, but because we are videotaping this for future reference, for future classes, for your own review, for that matter. So we're using the microphones so we get pick up back there. The other thing, just before I start, I want to comment that you will see a couple of our faculty members here get up and go at about 2:30. And that has no reflection on you, but one of our former distinguished professors here, Brian Wolf, died recently, and there is a memorial service for him this afternoon at 3 o'clock. And so a couple at least of the faculty are going to be leaving to go to that. So when you see them get up and go, that's no reflection on you folks. Necessarily, yes. Well, if they get up before 2:30, we'll know.
We might make an exception.
So let me start, actually, when I start at the far side and just work across, and that's probably how we'll have the speaking. I'm going to introduce all 4 of them straight away, and then they can just take off. So on my far right, on your left, is Denise Thomas. And Denise worked at the BC Center of Excellence in HIV/AIDS as a clinical nurse leader in the immunodeficiency clinic. But she spent the past 5 years working for the Clinton Foundation in Africa and India as a global clinic advisor and consultant on HIV/AIDS and health access initiatives. She was responsible for the foundation's clinical support team in mentorship, nursing policies, program and pilot designs and evaluations, and so on. So a huge amount of international experience. And Lesotho, you were saying, most recently. And she now has returned to Canada and serves as a nurse coordinator in the HIV/AIDS and sexually transmitted infections and bloodborne infections, there's a mouthful, in Health Canada's First Nations and Inuit Health branch or division. It used to be called branch, and they don't call themselves branch any longer. So it used to be FNIB, and now it's FNI. For the Health Protection Directorate here in Vancouver. So that is Denise, and so she brings that international and now First Nations experience and background. Next to her is Mike Pennock, and Mike is someone I've known since the early 80s. At the time then, he was Executive Director of the Social Planning and Research Council for Hamilton Wentworth out in Ontario. And he was also before that, or after that rather, research director of the Population Health Research Unit in Halifax for 10 years. So he's sort of spanned the country. And then he was 6 years at Vancouver Island Health Authority as a population health epidemiologist and researcher. And quite recently has taken up a position with the Provincial Health Services Authority as a population health epidemiologist there. His background, and he says here many, many years ago, was from the University of Waterloo with a Masters of Applied Sciences degree in Applied Psychology. So a somewhat different route into public health. Joan Gerber, next to Mike, is currently Executive Director of the I always have to read it off, Healthy Women, Children and Youth Secretariat. They keep changing their name, that's why. I've known and worked with Joan for the past 9 years since I came to BC, and she's been a pleasure to work with. She's responsible for women's and maternal health, child and youth health, and women's issues. Over her career, she's worked in Saskatchewan, in Alberta, and as well as in BC. She holds a master's degree in public administration, a Bachelor of Nursing, and a psychiatric nursing diploma. And she currently volunteers on the board of the Victoria's Transition House and is involved with the upcoming Canadian Association of Perinatal and Women's Health Nurses Conference in October. And so she'd be happy to get volunteers to help from any of you who want to be part of that. And then finally at this end we have Ted Bruce. And Ted is currently the Executive Director of Population Health with the Vancouver Coastal Health Authority, and he's also actually the Acting Director of Aboriginal Health for Vancouver Coastal Health Authority. So in those capacities, he's responsible for developing the Health Authority's strategy to address the social determinants of health. And I can tell you from having worked with Ted for the last 8 or 9 years since I came to BC, he has been very important in developing and applying the principles of population health and social equity, and really concerned about those and raising those issues and organizing conferences and events and pushing this agenda through Vancouver Coastal Health Authority. He's also currently the president of the Public Health Association of BC, and in fact his successor is right here in this faculty, Marjorie MacDonald, who has an applied chair in applied public health, and in November will be succeeding.
Subject to election.
Subject to election. Oh, we have a competition, do we?
Well, there may not be, but it hasn't closed yet.
Cool. So Ted has been very involved in that, and he has 25 years of experience in various policy development, planning, and leadership positions, and he came to this position, or to this, through the route of a master's degree from the Master of Arts degree from the University of Regina. So I'm not going to say any more about them. You'll learn a lot more about them as we go through the next hour and a half, 2 hours together. And so let me ask Denise, and if we can just make sure that the microphone is near you so that they pick it up at the back there. You don't need to speak right into it, but I think that'll pick it up.
Great. Can you hear me all right? Thank you, Trevor, and thank you to the faculty. And congratulations, University of Victoria's First School of Public Health and Policy. Very exciting and an honor to be here. As Trevor mentioned, I spent the last 5 years of my working career in Africa, very life-changing, and I didn't think I was coming back. But it all started when I went to nursing school in early or later 90s. And at the very end of doing my Bachelor of Science in Nursing, I took a practicum to Nepal. And it was there where I had an opportunity to see geographically marginalized patients accessing care. And it was through a mountain clinic in the middle of nowhere. And we were walking down to a clinic that was donated by a group of trekkers. And the trekkers donated the clinic because the villagers had carried his wife out for about 16 hours on their back. And so he decided to open up a clinic there because he knew that they needed it. And so there I focused my career on serving geographically challenged clients. And so from there, I worked at the BC Centre of Excellence in HIV. First of all, on the HIV ward, which is in St. Paul's Hospital, the only one of its kind really in all of Canada. It's on the 10th floor of St. Paul's Hospital, located on Burrard Street in Davie. Beautiful view of the water, English Bay. And so there I was seeing a lot of clients who were accessing care and treatment quite late, hence their hospital admission. So about 20 beds, a lot of clients coming in with opportunistic infections, a lot of very vulnerable people, very marginalized. So from there, I was recruited from my colleagues to work with Doctors Without Borders. Said, no, Denise, you should come and work with us in Africa. We're going to the Congo. they need you there. And I thought I wasn't ready. I'd only worked 2 years in the field. So from there, I worked with the BC Centre of Excellence in HIV as one of the nurse coordinators and leaders. And I was tasked with the job of identifying the role of a nurse in a specialty clinic. So focusing on system strengthening activities, looking at the wait times for our HIV positive clients. So to see a dermatologist, it was about 3 months. So it was very system focused. So I started looking at wait times and using different change models with the team. Found it challenging to get buy-in from the staff. I was the lowest and newest member on the team. So quite often the team meetings that we held were poorly attended. So I didn't have the power, but I had the responsibility. And so from there I learned about building teams using the Plan, Do, Study, Act model, which is something that the the Institute for Healthcare Improvement mandates as the key change model. So that was something that WHO as well has advised international communities as looking at this model. And so slowly by slowly, we're able to show that by meeting and showing our results and showing the cost savings, particularly the cost saving, we were able to implement change. 2 years later, I was ready for Africa, and I volunteered with the International Centre for Equal Healthcare Access. I was one of the nurses, the only Canadian on an all-American team, 2 nurses, 2 doctors, and a social worker. We were working in a country called, it's spelled like Lesotho, but it's Lesotho. It's a landlocked country, 2 million people, with an HIV prevalence of 29%, 1 in 3. And so treatment in 2005 had just arrived. Finally, the government was able to purchase it because it was affordable. That was where the Clinton Foundation's HIV/AIDS initiative had worked on decreasing the cost of ARVs, the antiretrovirals, which is used to treat HIV. And so from that experience, we're able to see rapid scale up through what we called clinical mentorship. It was in policy, it was theory, but it wasn't implemented and piloted in resource-constrained settings, such as Lesotho, one of the poorest countries in the world, one of the largest prevalence, with its neighboring country, Swaziland, HIV. So it was a 6-week pilot. We saw rapid scale up. I used the same back pocket change theory, which is Plan, Do, Study, Act, able to cheer the team on, share the importance of having a team meeting with all the stakeholders. At that time, it was the physicians who were new to the country. They were from Cuba. And we had local nurses that were tasked with implementing the program. So we were able to build a team. We saw rapid scale up. And then the government invited us to come back and implement it nationally, outside of 2 districts in Lesotho. Very empowering to see rapid scale up and work with our partners, Doctors Without Borders, and a neighboring organization in another district. So from there, my 5 weeks of volunteering turned into 5 years. Other countries wanted the same model to scale up their HIV programs. So it was doing the same demonstration again and again, adapting policy that was specific to each country. So the first request outside of Lesotho came from Mozambique. Their challenge was children had a difficult time accessing care and treatment, particularly children who were HIV positive. Healthcare providers found it was a specialty and were reluctant to provide care. Therefore, they would write in their medical bukanas, their medical booklets, refer to a specialist, which was translated to everybody as a death sentence. When we saw refer, we knew that they couldn't afford the transportation, couldn't afford the multiple visits because the system wasn't pulling the baby through the clinic. So we were looking at public health approach to make it simple for first-line care for children. And so we were able to tailor a clinical mentorship model with very motivated experts in the country. This was the ideal model. We didn't need expatriates coming in with treatment experience like myself from Vancouver. Instead, we were working through the local experts. And they couldn't wait to start training their neighboring clinics. They were motivated to train because it meant a decrease in the number of patients they would see if they trained their neighboring clinics. So it was very moving to see this happen, one country after another, Zambia, Zimbabwe, Ethiopia. Ethiopia was different. We had to get buy-in for prescribing a particular formulation of antiretrovirals. Our specialists liked to prescribe liquids, but the liquids turned into a stigmatizing formulation because a woman carrying a liquid formulation of antiretrovirals on her head meant her child was HIV positive. And so we were advocating to pharmaceutical companies to create a fixed dose combination for infants, which would then dissolve in breast milk, ideally clean water, but breast milk. So it was equal access. And so I would do a cooking show. I call it the cooking show, a table like this. And we would just run through scenarios showing how difficult it was to treat children. But we still wanted to affect policy and have impact on policy from a bottom-up approach. So that's, it was very exciting, happened one country after another, and then all of a sudden 5 years hit me. My nephews are getting older, and an email came. Health Canada was looking for an HIV nurse coordinator to decentralize HIV treatment and care on reserve in BC. I thought, is this really the job? Wow. I felt prepared. I applied, and a year later, I was invited for an interview, and then about a year later, I was hired. So it was kind of in the planning process there. So I now work at 1138 Melville Street in Vancouver. I work with nurses on reserve. We have about 150, over 150 health facilities, nursing stations, health centers with treatment, without treatment. The communities are anywhere from 20 to about 3,000. And yeah, that's where I'm at right now, and I look forward to questions and learning more about you later. Thank you very much.
Thank you, Denise. And what I should have said, two things I should have said at the outset. One is that we've tried to find people who reflect in one way or another the four areas of focus. So Denise is working now in First Nations and Inuit health and reflecting the Indigenous health component of our program. Mike sort of, to some extent, reflects the issue around public health informatics and the use of information and research and so on. Joan reflects the public health nursing area of focus and Ted the social policy focus. You'll find, of course, that none of them are rigidly within those boxes, but that's the sort of, we wanted to pick that up. The other thing that I should have mentioned, and it was Denise talking about Nepal that reminded me, is that one of the things Mike has done in addition, which is very interesting, is he's worked in Bhutan to develop the community health survey for measuring gross national happiness. And I'm sure he'll tell you more about that, but that's a very interesting twist on the notion of gross national product, and instead in Bhutan they choose to measure gross national happiness, which is such a nice sounding measure.
Thank you, Ted. Trevor. Whoever. I'm old enough now that I can just brush those kinds of mistakes off. As Ted said, as Trevor said, I graduated some time ago with a master's degree in applied psychology. My interest in those days, this was the early 70s, my interest in those days was in measurement. I've always been interested in research and measurement, and program evaluation. I had no idea why I had those interests. It wasn't something I aspired to do when I was 7 years old. In fact, I think when I was 7 years old, I wanted to be a detective with my own shoulder holster. Didn't think anything about psychology or measurement. But I had it was an interest that came to me during my years in university, and that was kind of the heyday of community development in Sololinsky and a lot of things going on. So this interest took me into the idea of measuring things in communities and measuring change in communities and looking at the impacts of things in communities, which took me, after graduation, after a short stint with the Addiction Research Foundation in Ontario, to the Social Planning and Research Council in Hamilton, which was an absolutely fabulous, unique experience. First of all, it hooked me up with people like Trevor and Mike Hayes and a number of other people who happened to be in the area. And as executive director there, it was a voluntary agency with the board of directors and could do wonderful things. And one of the really unique things about Hamilton in those days was they had an incredibly innovative and creative public health infrastructure. It was one of the original teaching health units where the public health unit that was part of the municipality was linked with some very creative people at McMaster. And there was all kinds of interest in how can we bring health and social together. And it was just one of those eras that unfortunately dissipated. And it was a very exciting time for 10 or 15 years. And so I was involved in a lot of that with some of the folks from McMaster and the health unit. And then in the early 80s, and I can't peg exactly when this happened, I was asked to introduce a speaker at one of the big McMaster events. And the speaker was a guy named Fraser Mustard. And if you don't know who Fraser Mustard is, you will, I'm sure, by the time you get through this program. And what Fraser was talking about was his latest big developments in something called the Center, Canadian Institute for Advanced Research. And it was something they were calling the Population Health Framework. And so Fraser came in and gave this great presentation on this newly emerging thing called the Population Health Framework. I bet your Mike was at that presentation. And then they asked Fraser to develop a graduate program in population health at McMaster, and I was asked to be a tutor in it. So I got to sit through it, and they just brought in all these fabulous speakers, and just amazing things happened. So suddenly the population health framework was out there, and it was the way of bringing together the social and health and the physical and the economics and so forth. And it was really a whole new paradigm, a whole new way of looking at things. Which just reinforced all the things we were doing. So it's a very exciting time. And then I ended up going off, as Trevor said, to Dalhousie University. I actually went off to grow herbs and stuff in Nova Scotia and grow apples, and somehow ended up at Dalhousie University. And where I was research director of a brand new unit again, Population Health Research Unit, which I was hired very early on, and we could develop this research unit in community health and epidemiology. And it was during that period that I really started, I guess, I took on epi skills. So many of the skills from epidemiology to research are completely transferable anyway. And we call the same things different things in different disciplines, but the skills are the same. So it was during that period, I guess, that I started taking on what you would call the more traditional epidemiology skills. And through being involved in research and data through FRU, Population Health Research Unit. During that time, I also got hooked up with a fellow named Ron Coleman, who was and still is executive director of an organization called GPI Atlantic, which GPI stands for Genuine Progress Indicator. And what Ron and a whole lot of people around the world are interested in is new measures of progress, different measures of more inclusive and broader measures of progress, rather than just, as Trevor was saying, relying on economic measures. Ron, after I moved to BC, Ron had become involved with this country called Bhutan, which is just underneath, used to be Tibet, no longer is, on the Himalayas, just south of, about the same size of Tibet. And they had developed this concept called gross national happiness, which was that they're a Buddhist nation, and it reflected their Buddhist view of the world and so forth. And so Ron had been part of an international group that had helped them flesh out this framework. If you want to measure gross national happiness, what are the concepts you want to measure? So when it came time to develop the measurement, Ron called or sent me an email and said, how would you like to go to Bhutan for a few months and help them develop this survey measure of gross national happiness, which it took about 3.5 seconds to say yes to. Unfortunately, VHA was willing to give me a leave of absence. So my wife and I both went off, and my wife Martha's very involved in this too, and we spent 3 months in Bhutan developing this survey, and we've stayed involved. So that's the point. We've developed a shorter, less Bhutanese version that's being pilot tested in different areas. So it opened up this wonderful opportunity to get involved in some international work here in Brazil and a number of places, which has also happened. Joined VHA initially as a population health epidemiologist, and then there was a reorganization about 1.5 years ago, which I was moved into the planning department and made director of population health assessment and epidemiology. And the intent was to bring population health thinking to acute care. I think one of the things, even though there was this big, a lot of excitement about population health in the early 80s, we've been less than successful in terms of our applications. I think still a lot of excitement about the concept, but there's still a lot of challenges in its applications, particularly within the acute care sector. So I was involved in the planning department in what's called the third floor of Begbie, which is the corporate headquarters of VHA. So it gave me some interesting experience in terms of a $1.5 billion health authority from kind of the executive corporate level. And maybe it says something about what that experience was, that I'm now working with the Provincial Health Services Authority, back being a population health epidemiologist, doing the stuff that I really love, except doing it on a provincial level. So I think one of the things that the population health framework has done in terms of revolution, I think, public health, is because the population health framework is about all the determinants of health. it has made public health incredibly multidisciplinary. It has had to be multidisciplinary because no one discipline can, the perspective of one discipline can deal with all the complexities of population health and the determinants of health. And so help make it just such, it's probably the most multidisciplinary undertaking, and one of the things that makes it so exciting, in my view, and just looking at the panel and the backgrounds, and we all work in public health, and where we came from and what we do are quite different. So I think I don't know what kind of career choice you made, where you plan on going from here, but if you find this business half as exciting as I have, you'll find it very worthwhile. And the other thing I say about my career is honestly never planned it. I never did probably 3 hours of career planning in my life, other than somebody sent me an email and said, hey, there's a job here, make sure you'd be interested or something. Then I'd sit down and do some career planning. But my career is just something that largely happened to me. I followed my interests, and that's something I highly recommend. People follow their interests. And I don't know where my interests came from, but they were there, and I followed them, and really haven't regretted very much of it. So, did I get in under my 10 minutes? Good.
So thank you. And again, just before Joan starts, it just made me think Mike's reference to all the disciplines it takes to make people healthy and to make a community healthy. And in fact, we left up at the back here the pictures you all produced yesterday. And if you think about some of the disciplines that would go into creating some of the elements of your vision of a healthy community, we've barely scratched the surface with the four of them here and the rest of us. So that's a huge part of it. Joan, over to you.
Thanks, Trevor. Can you hear me? I feel like I'm so tiny here, sitting here. Can you actually see me? I need like a booster seat or something. So anyway, Trevor asked me to talk about my career path and public health nursing work experience, and he gave me 10 minutes. So considering I've actually worked with nurses who trained before DNA was discovered, this is really going to be a Learjet kind of experience for me to put you through what I've done over my career. So it shows you how long I've been in this area as well. I think my path into public health nursing has been fairly short getting into it, but very convoluted. And so when I see public health nursing, I think of it as very, very broad and hugely expansive. So instead of taking sort of a direct line like the Trans-Canada line from Calgary to Regina, say, I had to take the ferry and, go over on the mainland, and I drove through the mountains and I ended up on some path in Jasper. So that's kind of how my career path left, and which is why Mike and I were talking about why we'll never retire, because we've never really stayed long enough in any one place to get any kind of a retirement package. But so anyway, you get the point of how long I've been around. But what I thought I would try to do is describe some of the experiences. And I really sat down this week and thought about what are some of the significant impacts and experiences that I've had in all the different jobs I've had that have led me to where I am. And so I'm going to take you on that little path. The very first thing that I did when I finished school was I took psychiatric nursing. I always was fascinated with the whole mental health piece of people. And so I ended up in a fairly traditional psychiatric nursing world. One of the very first positions I had and jobs I had was in an old psychiatric institution, actually in Saskatchewan. It's sort of like, if you can imagine One Flew Over the Cuckoo's Nest, we probably weren't that far away in terms of the look, although we didn't treat people nearly like that. And I was engaged in a position where we did some outreach. And so the position was that we had to travel all over, how broad Saskatchewan is, and there's, all these little towns. But one of the calls that we got was from a family who the woman was having a psychotic episode. So what would happen, I discovered, is that whenever it was a family situation, and whenever the family situation kind of rose up, her husband would actually hide her antipsychotic medications, which would put her in a breakdown position, and which would mean that we would have to bring her into the facility and hospitalize her for some period of time, and it would give the whole family then a respite. So that was one of the very first learnings I had about, oh my gosh, we have families out in the community that are really struggling, and you have to go to these kind of extents to actually have a break. So that was my first sort of view of community life and mental health issues. I also had an opportunity to work with mentally handicapped folks, and also one of the individuals that I worked with closely was actually a little boy. He was 10 years old, who had the results of untreated PKU, and so had major developmental problems. He was your traditional child, bright blonde hair. And it just made me realize how far we've come in terms of identifying and treating those children who have PKU now. The other area that I worked with phenylketonuria. And it's what's that?
Say she's sorry she asked.
And it is a genetic condition that is now picked up at birth. It's done, you pick it up through a blood screening test, and it can be treated, but you have to treat it right away. Okay. Yes, they don't metabolize a certain protein in there, yeah, so it causes.
Lots of public health nurse always.
So when the other experience I had was working in a forensic psychiatric facility, and I worked two people particularly stand out in my mind. One of which was a man in there for armed robbery who was actually born in a prison, and the other man that I worked with, I don't even remember what he was there for, but he had FASD, fetal alcohol spectrum disorder. And those two people had very significant impacts on me. And that whole experience also made me realize that I was way too young and way too stupid to be working in that position. But anyway, we could talk about that a lot another time. So these situations really affected me in terms of sort of showing me the impact of prevention and public health interventions and the whole maternal child health, the importance of maternal child health in those early years. I then took nursing, like registered nursing, and it sort of continued to cement my interest in the whole maternal child health. So this is kind of where I was going. I worked on pediatric oncology at Alberta Children's Hospital. I also worked with outreach for children who had speech language problems and developmental problems. And that's where I learned about the whole issues around the pain and grief that families experience with children who don't develop normally, children who are parents who lose children, and I really started to become even more interested in that whole maternal child health piece. I actually also worked in public health nursing in communicable disease control. That was an area that it was interesting, but it wasn't my passion. I moved out of there quickly and back into regular public health nursing. So did a master's in public administration, found myself in Victoria, thought, oh boy, I've moved from the lowest income area in Calgary where I was doing public health nursing, and I thought, oh, okay, Victoria's going to be a snap because I have landed in Lotus Land and everybody's got money here, so I'm not going to have any issues. Well, the first home visit I did in Victoria, I walked to the front of the house and the doorknob fell off the door. And I thought, oh boy, this does not bode well. So I think that when I reflect back on all of my work experiences, just to top off the experiences again that kind of really formed my interests and the direction I was going in, are things that affect, again, maternal child health, looking at the social determinants of health, looking at social inequities. The biggest experiences of individuals, and this is the nurse-client perspective that I had, was number one. A woman I worked with, she was new to the country. She did not speak English. She had a baby and went into postpartum psychosis. She had she was actually catatonic. Her family was trying to keep her at home. They didn't want to release her to the hospital. That was my first experience with postpartum depression, and specifically postpartum psychosis. Another situation, a school where, of course, public health nurses often went into the school scenario and had a school assigned to them, and where I actually was called in by the principal of an elementary school and was told that he had a grade 1 and grade 3 brothers, who actually went home from school the previous day, and their parents weren't home and didn't come home the entire night. And these kids got themselves back to school the next morning. And so dealing with that situation of parents who just didn't come home. So those two issues of poverty, again, just going into homes where you're absolutely astounded at the conditions that people live in. You know, coming from a fairly, not a well-to-do family, but I would say lower middle-class family, it was astounding to me, and that was something that really affected me. Smoking. This isn't as bad now, but going into homes where there's a newborn infant laying in a little bassinet and everybody in the family is smoking, and like it's blue in the house. Those situations. Feeling the helplessness of working with a mother who is experiencing interpersonal violence, being essentially abused by her husband every week, and dealing with an infant and a young boy at the same time, and feeling helpless and wondering why she just doesn't leave. And becoming, as you become older, you become so much more knowledgeable about why she doesn't leave. Witnessing some really poor maternal infant attachment and going, what the heck is going on and what can I do about it? So all of those things, feeling really helpless and really requiring support to work through those scenarios. So those, I think, are some of the bigger influences that have had an effect on me. And I think that working with families has given me certain perspectives. And my perspectives are, first of all, that I attempt to approach everything in a very holistic manner. It's very hard to parse out all the contextual pieces that are affecting families out there and say, okay, well, I'm only going to deal with the smoking, but everything else is so integrated. I'm very aware of the inequity issues and very aware of the huge effects of social determinants of health on individuals' lives. And I think particularly I've really grown to understand and appreciate the critical importance of the early years, and specifically maternal child health, family health. So I think, if I'll just wrap this up, the position I'm in now is the Executive Director for Healthy Women, Children and Youth Secretariat. We work a lot with our health authorities in the areas of those particular maternal health, women's health. And the big project that I'm working on now is a maternal child health program. And we've just announced funding, and we're working with the health authorities to implement the Nurse Family Partnership Program. It's a program that is developed by Dr. David Olds, and it has significant effects on the outcomes of children's health and development and maternal health. And so we're pleased that we're going to be working to promote that or get that program underway provincially. And coincidentally, we got a congratulations from Dr. Fraser Mustard for for doing this. So that's very positive. In closing, I'm going to just reflect on, I started thinking about all the public health nurses that I've worked with that I think really, really contributed a lot. And so I pulled out their characteristics. They never gave up on anyone, really. They never. They were always able to pull out the positives. and they had respect for the individuals when it was really hard to have respect. They never created dependencies. They were able to create the trust really, really quickly and had a softness about them, but were still able to really have those hard and difficult conversations with families. They were really flexible and had a sense of humor. So those are the characteristics that I see really positive in a public health nurse and a working relationship. But I also think that what makes a really well-rounded public health nurse is having a broader interest in systemic issues beyond their own practice, beyond the nurse-client relationship, and beyond their own community. And these are nurses that affect change. They're interested in change. They're curious about everything. They're curious about research. They're happy to get involved in research. They're interested in policy, and they're interested in how the political process works. And so I think that those make a really solid, well-rounded public health nurse. And I'm really hoping that this is what the new School of Public Health will promote. So if you, I'm happy to answer questions and or talk to you after.
So no little side commentary before I start, Trevor?
Well, actually, I
Thinking that's just a...
I shouldn't have asked.
Yeah. That's just a really great list of characteristics. I think we really should take that and probably stick it up on the wall or put it up on our website or something, because that's really powerful. Thank you. And
Yes.
Ted Bruce.
Yes, well, and also it is a small world when you get on panels like these. Was it the Weyburn Mental Hospital?
North Battle.
Oh, they're too bad, because I did spend a summer as a student working at the Weyburn Mental Hospital with the little white bow ties and things, and actually I think we did treat the patients like one flew over the cuckoo's nest, unfortunately, and that's, unfortunately in those days it was that way. So first of all, a little plug for the Public Health Association of BC, because I am the president, and Marjorie likely will be the next president. We are an organization which I hope you consider joining. It really is a voice for public health, a strong advocacy voice for public health, so consider that. I was thinking about the happiness index, and one of the things the Public Health Association does is hosts webinars, and we have a webinar coming up about the Stiglitz Report. And the Stiglitz Report is a big study that was done looking at a different way of measuring social progress in society, and so we have a webinar coming up on that. Having said that, Public Health Association BC does such a good job, it's sold out, so you won't be able to register now, but consider it, because we do very topical kinds of work. So let me, I'll try to ramble a little bit around my career and not go through it systematically. I was, in reflecting on this, it was kind of fortunate because I'm physically changing my office location right now, and I've been cleaning out files and boxes and throwing things out wildly. So I thought I'd do a little show and tell almost, and picked out a few reports that were sitting in various piles over the last number of years that I've collected, and use those to reflect on my career. So right now, I'm Executive Director for Population Health, and this is sort of the Bible that we use. It's our framework for what we do in population health within Vancouver Coastal Health. And interestingly, Mike, there is in there the framework itself of population health that you talked about. And so the work that we do, and I lead a small team that tries to activate the whole health authority around this, is we try to get the organization to provide more leadership around social determinants of health, population health issues. So leadership is one big piece. We do that by building partnerships, lots of partnerships with municipalities, and you'll find in public health careers, a lot of what you do will be working through partnerships with community, with other organizations, levels of government, etc. So we do a lot of partnership work. Policy development, I mean, the theme across all of these is all of us have a passion about policy. Many of us have worked in situations where we do one-on-one individual work, as a public health nurse would do in her sort of basic kind of career. But all of us escalate that. And we tend to escalate it because we know that the individual interactions are important. They make a difference in people's lives. But we have to change the system. The system is what is often causing the problems that we see. So we need to have a policy focus in the work we do. And then the fourth area that I work on is advocacy, and really trying to stand out and speak out about some of the big issues related to social determinants of health. And that's not easy to do. Most of us work in organizations which don't like to have the hand that feeds them bit. Is that the right way of putting that? But, kind of constrain what you can do around advocacy. And so it is a role that you have to kind of manage within the public health system, but is a very, very important one that we perform. So that's the role that I currently provide. It's kind of a 10 out of 10 job right now. And I think in terms of characteristics, as Joan was saying, there's several things about the work that I think are important. And it picks up a little bit on what Mike was saying. I mean, first of all, it's a good place to work because there's leadership in place around population health. Our Chief Medical Health Officer, and I think because of some of the work we've done on our Chief Executive Officer, there's really a degree of leadership around trying to address health and not just health care. And that's a very important differentiation. There is a commitment within the organization. So we've created a small team. We've protected that team. We haven't shuffled people around as some of us have sometimes experienced in our careers. So there's that commitment. We have a great team. Working on a team is always critical. And we have a certain amount of independence to develop our own path to try to create some of the change that we think is so important. And I think fundamentally, and this kind of gets to Mike's point, I think, is that we work with a group of people who hold similar values and similar goals. And that really is a set of values that you have to feel comfortable with when you're in an organization or in a career. Because if you don't, you're going to burn out pretty quickly. And I think the final characteristic is that we are achieving some things. One of the, I guess, best pieces of advice I give to people as they go into a public health career is that you're going to be working with a lot of ambiguity. It's not, we're going to do this and people are going to stop smoking tomorrow. We take a long time to create change in public health. And there's complex environments and you're pulling a lot of different levers and you're not sure any of them are working. And a lot of time you think you're just talking to the same people. So there's a lot of ambiguity. It takes a long time to create change and affect change in a career. But if you take a long enough horizon, you actually do some of the changes. And when you talk about smoking, well, I guess congratulations, University of Victoria, who I understand from the radio has just banned smoking on campus. So that's a huge step forward. And it's a policy and institutional change that creates change for individuals. So that's what I'm doing now. And if I kind of wander around a little bit and think about how I got to where I am, I would characterize the work I do as health systems design work. Most of my career has been in planning and policy development. And many of you will probably find your way into public health through that route. When I started, I was hired by the Saskatchewan Department of Health as a research officer. And in my current career, I hire graduates from Masters in Public Health programs in a variety of similar kind of roles. They may be project managers. They may be sort of working on one very specific project. They may be research officers. So they come in at a fairly entry level. Sometimes those jobs are hard to create full-time, so we contract people in for a year to work on a particular project, and then starting to build the career from there. And that's what I did when I came into this business. So planning, research, but really always with a focus on health systems design. As I pulled another document off my shelf yesterday, one of them was the Royal Commission on Healthcare and Costs, which was done in BC to try to revolutionize our healthcare system here in British Columbia. And at the time, I was the policy analyst and policy director for the Registered Nurses Association of BC. So that was a role that I came into initially to lead their policy work to influence healthcare policy, but healthcare policy with the emphasis on health. Nurses have a very strong orientation not to thinking about health as healthcare, but thinking about it as health. And I remember addressing the board of directors of that organization the first week I was there, and I was introduced, and someone said, "Tell us what Health for All is all about." And I realized that's the first time that in an organization I had someone actually talking about the Health for All movement, which is kind of where we all started in a way. And so if you look at the health system design work that has been sort of the focus of my career, it really stems back to the Alma Ata Charter. And if you haven't read the Alma Ata Charter, you should read the Alma Ata Charter. And I won't say very much more about that, but maybe you can go Google it and read it if you haven't done so. But it really spells out what I think all of us are about in terms of trying to produce health in communities. And when we work in the healthcare system, what that system needs to look like to actually produce health in communities. So, that involves things like building greater community control, giving communities control. So you need to look at regionalization of healthcare. We haven't got a good regional system of healthcare in BC. We were getting there at one point, and then we collapsed into these big corporate organizations. So giving communities control, building community capacity. Most of us have probably done some level of community development work. I mean, healthy communities movement being another health for all kind of buzzword. I mean, when I was in this job with the Registered Nurses Association, we did healthy communities workshops throughout British Columbia to try to show people, demonstrate to people how to think differently about their health in a community and how to try to, from their community power base, change the way the system operated. And certainly a whole new kind of vision of primary health care and how primary care should be reoriented to thinking about prevention, promotion, and empowering communities to take control over their health. So that health systems design piece has been underlying a lot of the work. So I've only got a couple minutes left, I suspect, so I'm going to just jump very quickly to a couple of other things that in my career which I think kind of build on that theme, which is trying to develop health systems that really empower communities and change the power structure in society. I worked for the North Shore Health Region, which was a predator of the current Vancouver Coastal Health. And in there, again, was responsible for what we call systems development and performance. And I came to that role through a planning and policy career. So we got put in place there, and there was a lot of work looking at performance measurement, looking at performance indicators, trying to show the changes that needed to be made in the system by the way we measure it. So there are people from public health schools, graduates coming in that I use now that help us with the performance measurement work in public health. So there's an aspect of that Mike could, I'm sure, elaborate a lot more on. I was the executive director for primary care in Vancouver Coastal Health at one point for a number of years, trying to reform the primary care system, again, to kind of go down that path of alma ata. After 4 years, was not very successful at that. The system is very entrenched, very hard to make change. We're still working at that within the system, but I think there's huge opportunities there. In the planning role, I've had the Aboriginal portfolio under me, I think, 3 different times. I'm on my 3rd tour of duty there. And I picked out just one of the planning documents we did. And so again, being able to work with community, empower community to have a voice within the healthcare system and try to get the healthcare system to understand that it needs to change if it's actually going to improve health. And then to close, I kind of thought, well, how did I actually get into this path way back when? Because my Master's of Arts is actually in clinical psychology. And it was much the same route as Joan, where you realize, geez, I'm not making much difference here at these one-off-one kind of things. And so looked at policy environment and moved into to health in Saskatchewan and began working in a very progressive health department as a research officer. Moved to another government department in Alberta, again working in planning and policy development. And that will be, I think, a route for many of you. But I thought, where did I get some of the passion? Because it's the passion, the values that we have in public health, which will sustain you as you kind of wind your way around, as all of us have. And I remembered, as I was picking things off my bookshelf, I thought, where's that little red school book that I remember I always had in my shelf when I was in the early parts of my career? And I couldn't find it, so I Googled it. I couldn't quite remember. So the little red school book was actually a banned book eventually, because it was talking about changing the power structure within schools to put students higher in the power structure with schools. And so that really was one of the things that grounded me, and it reminded me of more of my direct action days when I was at university, where we actually were one of the universities in those days that occupied the university. And I remember, and so I Googled it to see if anybody had done anything about that little bit of history. It was the University of Regina, and I remember we tried to get the university name changed from the University of Regina to Louis Riel University. But they thought that was a bit too radical, because that guy sort of was a traitor or not a traitor, as my First Nations friends and Aboriginal friends would be able to comment on. So we thought Gabriel Dumont might be softer, right? We could get away with that, but that didn't work either. But there was an interesting article around the rebellion, the student rebellion in the 1960s in Regina, late 60s, early 70s in Regina, and I recalled that the passion was there for bringing about change, and I think that would be what guides a lot of the public health careers that I see. It's trying to create social justice, and as you go to your career, try to find those places where you know the value system is trying to create social justice, and I think then you'll find you make a contribution and you'll be satisfied in your career.
Well, thanks to all of you. And so now it's your turn. It's open season. You can ask anybody anything. They have the right to refuse to answer. We probably don't have today a protester to stand up in the back, but we'll all miss that, I know. We are going to ask you to use a microphone to ask your question, because we are taping this and we want to make sure that the sound gets picked up. So I'll leave one mic here for you guys to pass around among yourselves, and I've got a mic here, and I'm going to do the running the mic around business. So who'd like to ask a question or make a comment or express a thought or stand up and protest? There you go. And what, again, because we're still trying to get to know each other, introduce yourself, say who you are. It's all yours.
Oh my God. My name is Margaret, and my question was for the gentleman on the end. I can't remember quite who was who.
Ted Bruce.
There we go. Something you said reminded me of yesterday. We each got our own quote and we kind of had to think about it. And mine was, nothing is more fatal to health than an overcare of it. And you mentioned the importance of focusing on health, not necessarily health care. And that's still something I don't quite understand. So could you give us an example of what you mean by that?
Well, I think a good example would be that I'll just take more from a traditional public health kind of side of things. So let's say that the greatest concern in our healthcare system right now seems to be with chronic disease, so obesity, right? So the healthcare system is starting to focus on obesity. So the healthcare system response to obesity might be a surgical response. And believe it or not, there is a lot of work going on in this province looking at how to increase the surgical response to deal with obesity. Lots of effort going into that. So that's a healthcare response. A traditional public health response might be, well, let's encourage people to exercise. So we're going to get out there and we're going to tell folks to take your kids and walk around the block when you get home from work. Well, of course, for many people, as Joan was describing, that's not a realistic scenario for them. They may hold two jobs because of their income situation, their socioeconomic circumstances, etc. So you're not going to be very successful with that kind of health care response, that case of public health care response. So a health system response, which is concerned more with health, might be, what do we do to empower and enable people who may be obese to be able to get the exercise that they need? And the factors that we would try to address are those social upstream factors. So maybe they need to have better income. Maybe the built environment in the community doesn't encourage walking. The neighborhood's not safe. The person hasn't got access to daycare that they can afford, etc. So if you look at healthcare, the healthcare response tends to focus on how we fix the individual somehow through our interventions. A health response is, how do we change the environment around that individual to support them as they make those changes? So that's the difference between health and healthcare as I was thinking of it.
Does anybody else want to?
A quick comment on that. One of the, when I was talking about Fraser Mustard making a speech back in the areas, one of the really staggering and revolutionary thoughts that came out of that, and it's no longer staggering and revolutionary, but it certainly was then, was that a society could spend so much on health care, they start negatively impacting the health of the society. And they do that through two vehicles. One is that health care is dangerous and has negative impacts and negative effects. But beyond that, when you look at government expenditures, there are limits to the pot. And the greater the percentage that is going into health care means there's less going into education, there's less going into child care, there's less going into the environment, there's less going into all of the other areas of government activity that affect health as determinants of health. So for Fraser to stand up there and Bob Evans and some of the other people involved in that to say, look, a society can reach a point where they spend so much on health care that they start negatively affecting the health of their citizens was really, I don't know, it was kind of earth-shaking thinking in those days. Because what they were arguing was in those days we were spending 33 to 35% of government expenditures on health care. They were arguing we were reaching that point in the 1980s. Well, we're now approaching spending 50% of government expenditures on health care and haven't been able to turn it around. I think a lot of people would argue that we probably are negatively impacting the health of society through the percentage of resources that we devote to healthcare. So it's not just a philosophical concept. It actually really does have real implications in terms of the health status of the population.
And if I can add a couple more points to that, I have a mic here. If healthcare expenditure was what was the major determinant of health, you would expect the United States to have the highest life expectancy in the world because it spends more as a share of its GDP and more per capita on healthcare than any other country in the world. Well, it's about 27th in terms of life expectancy in the OECD. So clearly, spending more on healthcare hasn't helped them at all. Probably quite the reverse. And back in 1974, the Lalonde report suggested 4 health fields. And people generally still, in a broad sense, go along with those. Environment, meaning physical and social environment, lifestyle and personal behavior, healthcare system, and biology. And various people have tried to sort of figure out what proportion of improvements in health is attributable to each of those 4 fields. It's pretty crude and it's pretty unsatisfying, but generally the estimate is that healthcare contributes at best 10 to 20% to improved health compared to those other fields. So those are some of the other sort of macro scale measures of that. Somebody else? We'll go here, and then we'll go back up there. So you can just pass that back on.
Hi, my name's Dan, and I was just wondering, for anyone up there, what tools you've picked up over your careers for dealing with some of the red tape that's put in front of you to get around changing a policy that you would like to see changed.
You're in the middle of the red tape, Joan. You have to answer this. Yeah, she's matter of fact, she can't even talk about it. She's in such red tape.
Bureaucratic secrets coming out.
Well, the thing that in my current role that I'm in, the best tool we have is the Public Health Act. The Public Health Act makes provision for medical health officers to be appointed. And those medical health officers have some independent authority to report on the health of the public in their community. And so though I'm in an organization that will occasionally want to sit on us talking about things that might be embarrassing to government or whoever, the medical health officer does have the opportunity under the Public Health Act to speak out. So I'll give you an example. We were working with partners around child poverty. And the government here was not very sympathetic to the whole issue of raising awareness around poverty. And we're in a bit of a state of denial at times about that there was any significant levels of poverty in the province. I may be a bit harsh on them, so, I'll take that with a bit of a grain of salt. But we worked in partnership with the Child Poverty Advocates, Campaign 2000, and they have a press conference they do every year. And they release the poverty statistics. And we've been working with them to provide them the data and information that we have on the gradient of health and how socioeconomic status affects child health over time. Work that's done by Human Early Learning Program at UBC and others. And so we were invited to the press conference when they were going to release their report to be a validator of the report. So that's a bit tenuous because they get quite a bit of media attention in that situation. But we had our Chief Medical Health Officer, Patty Daly, participate on the panel. And we didn't get our chain pulled. I mean, there have been times when the communications gurus of the ministry of someplace, phone and say, "What are you guys doing at this press conference?" She was there, and what she did was speak about the evidence base and the facts that we have in public health. Didn't advocate, didn't suggest particular policy solutions or anything like that, but could speak from a strong evidence public health point of view. So that Public Health Act is a very, very important tool to use. And I would say as you go into a career where you're going to be doing advocacy and trying to speak out on policy change, your most powerful weapon is the evidence that you have and the public health perspective you can bring to that evidence. Because that's, in a way, when you get challenged around being partisan or something, you don't want to be there. But if you've got the research behind you and you can put that forward and speak to it, then you're on much safer ground. So that's the way we tend to deal with it.
Well, I just like to preface this by saying nothing is easy. And I just had a conversation with my husband the other day because he tends to have more socialistic tendencies, maybe, for example. And he said, well, if government would only function this way. And I said, well, the problem with that way of thinking is that you have as many disparate opinions as you have disparate ideas. And so the question is, how do you bring those disparate ideas and opinions together for a consensus? So, for example, you'd think that policy development is a pretty standard process. We have an issue. We've got the data and the evidence to show it's an issue. We figure out how to formulate what the resolution is going to be. We take it to the politicians and they say, yes, we will, this is the selection, this is what we want to do, and it moves into action. That's not at all, that's a very often rare way of actually happening. Often people are influenced by other people, by public opinion, and sometimes the evidence flies in the face of what the decision is. So I'm not sure what you mean exactly by red tape, because red tape is we have to sometimes go through a whole lot of bureaucratic kinds of things. But if I can just use an example, a real life example right now, which I'm not telling tales out of school because you guys have seen this on the news, a court decision by a woman who was achieved through assisted human reproduction. And the court ruled in her favor, saying that anybody who is born through assisted human reproduction should have the ability to know their biological roots. So as a woman, if I need to know who my biological father is, I should have access to that. So the court ruled in her favor, which then said to government, you guys have to figure out a way how to make this happen. Now, this is hugely complex. It is not a simple issue at all. It involves the fact that we get people who have assisted human reproduction get sperm you order it from the U.S. So, first of all, BC has no ability to regulate what happens in the U.S. So, the other thing is, how do you then you have competing rights. You have the rights of the child to know, and then you have another right, the right of a parent to have a family. And that so by affecting these sperm banks, for example, we may drive down the availability of sperm that's required. And so it has all these unintended effects. And so the issues are completely complex, and they're very rarely simple, and they involve a whole bunch of consultation. So I'm not sure if I'm answering your question, but it's not a linear process. It's not necessarily a sequential process. You've got things coming in every way. And so it's just figuring out, how do you catch those pieces and how do you deal with them and how do you account for them in your policy development?
Oh, Denise, I'm sorry.
Just to add to that, I think it's really important to keep a sense of optimism and really to keep a patient experience, a client's experience story in your back pocket, to always illustrate the point, because I think we've heard that through Joan's presentation, through Ted's presentation, or sorry, Bruce's presentation. Sorry, it is Ted, not Bruce. Is that it needs to be illustrated. And so I've learned to quote unquote can patient experiences, client experiences, to illustrate the gap in the system or the policy. So I think the policy piece, it's important that the lived experience of the client is also influencing policy, and it's top down, but then it's also bottom up. I found that that's really powerful in an example of that being in South Africa when President Zuma had publicly tested for HIV in 2009 on World AIDS Day, December 1st. And so now the action, the implementation piece around that was to equip the system. And approximately 300 of the 4,300 clinics were offering treatment. So it was a massive system change where the largest HIV treatment program in the world is doubling. 900,000 clients on treatment, and in a matter of months, 900,000 new clients were identified. Mass stadium testings, all of the premiers did public testings, had stadium testings, and then that linkage to care. Massive system implications where you had both public and private partnerships and needing to link everybody in to share their materials for one client. So I think one of the challenges in my profession has been to quantify the qualitative work that nurses do, particularly with your executive team members who are really looking at the most efficient way to deliver the care, but then also to then, from the nursing and the College of Nursing perspective, is to ensure nurses are working within their scope safely in order to serve for their communities. So I think it's been really interesting to see that the lived experience of one client is valuable, and I've had a hard time to defend that as a measurement or a metric for a successful program. But I think really in the back pocket, it is really important, keeping it practical. Thank you.
Another very quick piece of advice I'd give around in terms of organizational red tape is work for small organizations. There's, in my experience, the amount of red tape and I've seen bureaucracy increases exponentially with the size of an organization. So if you're going to go work for Vancouver Island Health Authority, you're going to be buried in red tape and bureaucracy. And you just deal with some of it you ignore. I'll also say I've never known anybody who's been fired for ignoring red tape. They may have their career limited, but I've never actually known anybody. I mean, Trevor and I are still gainfully employed. And if there are two people who paid less attention to red tape in their lives, it's probably he and I. So don't get too hung up on it. But I'm sure probably the best part of my career, most interesting, exciting part, was working for the Social Planning and Research Council in Hamilton. It was a 10-person organization, our own board of directors. We made our own red tape. And although there were some job security issues, we always had jobs. We always found the money at the end of the year. If you've got a choice between working for that kind of organization and working for one of the BC health authorities, go to the small organization anytime.
Health nurse on the North Island, and I guess I still haven't clearly got my vision of where I will go once I'm finished with this degree. And my question is kind of for the nurses, but it could be for the whole panel. I find that a lot of my passion comes from my one-on-one work or working with groups, and I hear that from you all as well. And talking about having the story in your pocket, you know, I think we carry that around a lot. I just wonder whether when you work towards more advocacy and making change and you move farther away from working with the individual, do you find that, I guess my question is, are you moving farther away from working with the individuals, or can you find a balance between that, or do you find that something you miss with your where you are now?
Thank you, Melanie. Excellent question. When I was working at the Center for Excellence in HIV, Dr. Julio Montaner, who is now the past president of HIV and AIDS, the International Society for HIV and AIDS, was very passionate about keeping everybody current. So whether you were an epidemiologist or the nurse coordinator, you had to stay current, which meant you had to know and keep your ear on the ground and work one-on-one with clients, whether it was a half day for his general practitioners or if it was nurses working in every single clinic. I've taken that through my career, and I do, even though I'm working in the for the BC region for First Nations Inuit Health, I do get the opportunity to go out to meet with community members, and that was another essential piece for the tool in your toolkit would be the relationships that you build with your frontline providers, so that you do have a true picture of what's happening on the ground. So even though I'm not providing frontline care, I'm getting out to different initiatives, interacting with the community, and still getting as close as I can to the community and the client. So which does still inform policy and informs a lot of what I do.
This is a really hard one for me to answer. I tend to think that often public health nurses feel that if you're no longer in practice, you're sort of out of date. I've had this kind of, a bit of that kind of feeling. Now, I've been away from individual practice for, it's almost my 7th anniversary at the ministry now. And what I would like to see is more of an ability to move in and out of that experience. So move into the health authority, move into the ministry, and have more opportunities like that. There isn't that right now. And so as much as I've really enjoyed working as an individual public health nurse, I can't say that I was ready to move on. And I moved on by becoming more of a manager of public health nursing and then moving into the more ministry level policy. But I do see, I really remain connected to my public health nursing colleagues. So I think that I probably don't miss it that much because of that, because I work closely with them. I do think, though, that if there's a possibility for more of those exchanges, I think that that would be hugely valuable, because I do feel that public health nurses would really benefit from a stint at the ministry to get a broader perspective of how things really work. In that area, in public health and the policy area.
I just like to reinforce Denise's point, because I think if you're doing policy and planning work behind a desk in front of a computer all the time, you're not going to be very successful. It really is important to engage communities, to be out in the community, understanding that perspective. I mean, the whole point of a lot of the planning we're doing is actually to empower communities around their health. So you can't do that from, your office all the time. In my career, I've been fortunate that I've had at times the portfolios for community engagement and community development underneath my organizational structure. So it does imply that you have to do participatory active policy development the same way you do participatory active research.
Good, because I was going to say that side's asking all the questions. So.
Thanks. Hi guys, my name is Steve. This is a little bit of a two-part loaded question, but I noticed the common theme of change coming up a lot with all of you. So the first part of my question is, what barriers to change do you often come across in your different levels of work? Because I know, Denise, it seems like Denise and Joan, you've both done a lot of individual work. Mike and Ted, it seems to be more higher level as well. So I'm just looking for commonalities and the barriers to change there. And I'm also interested in how you guys overcame those barriers as well.
Okay. Well, I think the biggest challenge I find in my current role is the differing value systems that we encounter in our current society. So you've got kind of the value system which is more collective in nature versus the value system which is more individualistic in nature. So if you talk about, we've got poverty as an issue that's affecting people's health downstream, you got one set of values that say, well, collectively we should deal with this issue. You got another stream, the other value set, which says, well, it's individuals' responsibility to, pull themselves out of poverty, etc. And that is a huge division in our society. And you see it playing out at the highest political levels. in Canada, United States, between the left and the right, or however you want to frame them. But it really is the dynamic that makes it hard for public health, which holds a collective value system and the notion of collective action to solve problems that may appear as individual problems, but are actually collective problems, hard to move those agendas forward when there's a whole cadre of our society which says that's not a collective issue, that's that individual's responsibility. So that's the big barrier. The way of overcoming that, I think public health is still learning how to do that, and it's getting smarter about how to do that. It's trying to demonstrate the value to individuals of collective action. So to some extent, when we talk about, gee, if we did these things and reduce poverty, you'd actually reduce the impact on the healthcare system because people would be using less healthcare and you'd save money and gosh, your taxes might go down. You know, that kind of argument gets sort of posed. But I think, you know, even pointing out that, you know, if we have this huge gap in society between the rich and the poor, your community is not as safe. You know, you're going to be living in a gated community and sooner or later someone's going to come for you. So it is trying to reconcile these two value differences in society and build the arguments that will win over people who see individualistic solutions as the only way going forward. That's the big barrier I find all the time that I'm trying to deal with.
I think one of the problems in any system, to take a step even further back, any system works for some people, and therefore they don't want it to change. And that tends to be the people who have benefited most from it, and sometimes are the most powerful. As I say, I'm an epidemiologist. I really do believe, because I've seen it many times in my life, the combination of data, evidence, and stories changes things. And it really does. And it's very easy to get pessimistic and skeptical about the amount of time we spend banging our heads against a brick wall. But if you stand back and look at what's changed in this country in 40 years and take that kind of perspective, it knocks you out. I mean, we used to put First Nations kids into residential schools and thought that was a good thing to do. I mean, can you imagine going into a community, pulling all the kids out and putting them into a residential school? When you look at the numbers back in the 60s of the percentage of the Canadian population that was institutionalized for one thing or another, whether they were in jail or in homes because they had disability, or in institutions because they had disabilities, it was unbelievable compared to what the numbers are now. So there have actually been huge changes made in terms of how we respond to people and their problems in the last 40 years, and it's easy to get hung up about, well, it hasn't been enough, it hasn't been fast enough, because we all feel that way, and obviously there's still a lot of change that happens. But when I look back, there really has been a dramatic amount of change that's taken place, and a lot of it has been driven by, you know, data and evidence and stories. When you go back to actually look about how this stuff changed. So I think it never happens fast enough, it never happens big enough. But it does happen, and people have been making it happen for some time. And that's not to say we don't suddenly, I mean, in 2001, I wasn't in BC at that time, but sort of from my perspective, a new government came in and and there'd been some steps taken forward, and suddenly there were some steps taken back, so change doesn't always happen in one direction. But over time, I would argue there's been a lot of change happen in this society to the better for the last 40 years, and it's because a lot of people have been pushing for it, and they've made good use of whatever resources they had to do it. So I think it does happen, and it can be overcome.
Thank you for your question. I think one of the challenges we're facing in the Canadian context in BC is being invited to high-level meetings where key stakeholders are involved. Which seems a little bit of an irony, where one thinks that First Nations Inuit Health would automatically be invited for, you know, particular planning and decision-making activities that are taking place. So it's a little bit, I think, the way that we're addressing that is through advocacy, sometimes requesting to be invited, sending emails, like from a very practical perspective, is advocating the value of having First Nations Inuit Health at the table. An example is there's a provincial initiative that's taking place. It's a $48 million initiative to link people who are HIV positive to care and treatment. And one of the key stakeholders, we think, is First Nations Inuit Health. Unfortunately, We haven't been a part of the planning process. And we had about 100 nurses that came to our communicable disease update meeting in February. 74% had never heard of this initiative. So when we're looking at marginalized populations such as First Nations clients living on reserve, one would think that nurses and community health representatives are the key gatekeepers to providing the HIV/AIDS information and education to their communities, yet they're not aware of the initiative. So they're marginalized structurally, but then also marginalized from a top-down perspective as well. So it's something we're advocating for, and as a nurse coordinator, I am meeting with other nurses that are providing care and treatment, because nurses who are providing care and treatment are invited to the implementation meetings. So our nurses aren't providing care and treatment, but we want them to provide screening and education and refer their clients. So this is the barrier. It's a huge barrier, but I think there's great opportunity, and I know it can happen. So I think I keep the positive, I keep very positive when I attend the meetings, invited or not invited, and share what is needed, the basic information, like the list of physicians who are accepting new clients who are HIV positive, so that a nurse can refer a client. We're looking at working with partners, key partners, to implement like a nurse based at the Center of Excellence in HIV, based at the clinic there, so that a nurse can have rapid access to another healthcare provider to help navigate the system. We're working with Vancouver Coastal's Aboriginal peer navigators to say that this is a system that's already in place, it exists, here's a way to contact them, very practical. And then in South African setting, when we were scaling up the largest treatment program in the world, the Minister of Health had asked us to train 300 nurses. So we collaborated with the University of Cape Town, system was in place. One of the barriers is getting the policy into the clinical setting. So if your frontline providers are unaware of the policy, the dissemination plan and the communication plan isn't clear. So keeping it practical, that your frontline healthcare providers have the policy. And in this case, South Africa was very quick to implement the strategy with key stakeholders, and the partners were less quick to implement. So again, advocating, believing that yes, they can have a copy, and whose budget will the photocopying come from? That could be a simple, very practical barrier. And, you know, looking at the international organizations, just knocking on all the doors and accepting no as an answer is okay, but then knowing that you can do it. So I think in this case, we actually, unfortunately, the nurses didn't get a copy of the guidelines because the volcano had erupted and the policies coming from Geneva were in a plane that was in Geneva somewhere. It wasn't actually get there. That was a fair enough excuse, but we just kept knocking and kept knocking. So it can happen at policy, it can happen down with your frontline providers. Thanks.
Probably not a lot to add, but I think that what Mike said, sorry, aging brain, facilitators are data, good data, but I think that even sometimes with good data, you don't get the change. And there seems to be other things that help facilitate it. In an era where there's lots of money, unlike now, you're more likely to get significant changes in policy and program direction. When there's no money, it's very difficult, no matter what data you're showing. Never underestimate the power of media and lots of letters to your MLAs.
My name's Jose, and I'm wondering if you're aware of the up-and-coming frontline practitioners and how public health is being implemented in their training so that they're already there, if it is, so that there is an awareness. I just think of my colleagues, and I think of my training where that wasn't, even my background's physiotherapy, and that was close to 20 years ago, but that wasn't even, you know, how we're training the up-and-coming professionals to to understand what kind of community we want to be working in as opposed to system. Healthcare, rather.
Well, I can't answer it directly, but I will talk about a little bit about competencies in public health. The Public Health Association of BC has been doing a project in large part initiated by Trevor in his Ministry of Health days, which were pretty recent, I guess. He initiated a project whereby we looked at what is the competency requirements for public health practitioners in BC based on these core public health functions that had been defined by the ministry for us to put in place. And we have done a couple of surveys of public health staff to kind of identify where there's gaps in their competencies now. We've focused so far only on 2 areas, and we're doing a third one. One of them was leadership and one is community development. And in the 2 areas that we've done the assessment on, the gap that people identify, there is a gap there in some of the competencies that frontline workers say, I don't know necessarily enough about community engagement or community building and that sort of thing. So but I was surprised that the majority of workers did say that they had that skill set. Now, this is people who may have been employed for a period of time, and it's not their entry-level education that built up those competencies. But I found that the data showed that, probably 75 to 80% of staff felt they had the competencies. What they did say, though, was that they're not supported to apply those competencies. So even though they know that they could do more community development, they're not, able to apply that because they're targeted at other work where they don't use that. So I don't know the direct answer. I know that when we have met with the schools around this competency project, I do get a sense that there is in some of the traditional public health professions, the material is being built in. They are aiming at the Public Health of Canada defined competency set, which includes a lot of what we're talking about. But it's probably in some of them less than others. I'm thinking, for example, there was a public health inspector, person trained as public health inspection here, and I don't know what kind of degree of emphasis there might have been on some of the population health stuff in that program specifically. But I am somewhat optimistic that there's a pretty good competency base. Sometimes, like in physio, it may be presented in a bit of a different way within the degree program, but you might be able to spin it and tweak it so it makes more sense. But things I don't think are as bad as we might think in terms of the competency set that public health people have to be able to move forward with population health initiatives. Yeah, I remember that competency is defined as skills, knowledge, attitudes. So, even if you've got a good, strong attitude, one of the things I find about nursing is that the reason it has really good ability to support public health, even if it's not public health nursing, but just nursing generally, is because the grassroots training for nursing is to actually support the individual to take responsibility for your care. So they teach, wound care, and they teach the physiotherapy gives you the exercises, then you need to go and you take that, and I'm not going to have you come back 20 times and I'll do the exercises with you. You need to. So there is an empowerment approach in a lot of the frontline health professions, and there's also a very strong caring attitude, which tends to sort of spin off a bit into the social justice side of things at times. So, there's a lot of roots there in the attitudes that can be built on, and then the skills can follow.
I've had very little to do with health education for some time, but one of the things that's always struck me is back when I did, in the days when I was involved in McMaster, was the things that we talked about as determinants of health in planning and policy making. In clinical care, they just talked about sort of holistic health or psychosocial health, and we're all talking about the same things, that a person's more than a wound, they have a living situation, and if you're going to provide good health care, whether it's in discharge planning or anything else, you need to take those things into account. And certainly in those days, health programs were promoting that, and it was part of the curriculum and part of the education. And I suspect, certainly from hearing from clinicians now, the biggest problem is what Ted's talking about. Often people do come out with those skills and interests, but the working environment doesn't really allow them to put them into place. But in my mind, holistic healthcare and determinants of health are just looking at the same issue from two different, one's a policy kind of community group perspective, the other one's from a clinical individual perspective.
Just to build on what you were saying earlier about the interdisciplinary education, for in-service education and pre-service education for HIV, there's interdisciplinary programs one is taking place at University of British Columbia. It's a 30-day intensive 3-credit course. So for nurses working on reserve in BC, it would be, a lot more to attend that course. So really, primarily, the nurses that are taking that course are Vancouver-based, and all of the case studies are Vancouver-based. So we're looking at something that could be decentralized for nurses working on reserve. And it's really great to hear what's happening with competency-based education, and it's great that that's coming back. We've noticed that is a gap in the education, the pre-service education for nurses in HIV. Quite often you'll have an HIV 101 presentation that has many competencies in it, and it isn't clear. So nurses are having to translate the policy and a lot of the materials into an HIV 101 for their communities, and it varies across the board. So this is something that we're hoping to standardize.
I think that cross-disciplinary training is becoming more and more of interest to people. Recently, I attended a workshop where there were primary care physicians who had maternity patients, midwives, doulas, etc. And there's a lot of misunderstanding between those practitioners, and certainly one of the major recommendations that came out of that workshop was that more cross-disciplinary education happens so that people begin to understand the constraints and what they can offer in terms of their professional expertise due to that misunderstanding or that turfism between professionals. That doesn't address the public health thing, but I think you could apply it to public health as well.
Okay, we've got a question from Jeff Redding, who's one of our faculty here.
Yeah, thank you to the panel. I just wanted to get your perspective on the global focus on public health. And from the presentation on sub-Saharan Africa, it seemed as though there was a former U.S. president who was employing a Canadian nurse as part of an international team that included Cuban doctors and nurses. So that seemed kind of interesting how that got put together. And then to address an issue where we actually learned about the situation in Canada and the learnings from sub-Saharan Africa improve the well-being or have the potential to improve the well-being of Canadians while building the capacity of the international community. So I guess a lot of students here are interested in, different issues around international and global having to do with global threats, global opportunities, the opportunity for a career that literally spans the globe. So it'd be interesting to get the perspectives of each of you as to where do you see the trends going in the future for like a cohort of this group who are just starting out.
Well, let me just throw some things out here. I had an opportunity just over a year ago to attend a large international maternal child health symposium conference in Washington, D.C. a year ago. It was all around the Millennium Development Goals. I'm not sure if you are not aware of them. There's several of them around maternal child health, around HIV/AIDS, around women's education, et cetera, et cetera. This one happened to focus specifically on women and maternal child health. There is huge opportunities out there in this specific area. And as you're probably aware, Stephen Harper made an announcement, well, just before that, around providing funding for international work pertaining to maternal child death in across the world in the international communities. What I saw, it was the most outstanding conference I've certainly ever been at. Everybody was there. The heads of literally every international organization, from the UN to UNICEF to Red Cross to you name it. One of the things that is specifically, I think that there would be a lot of opportunities is in that area, particularly in Africa, but not just Africa, Asia as well. So if people are interested in that, I would have to say that there's plenty of opportunities. And in fact, I came away from that thinking that this is my next step. So that's about what I can say, because I haven't worked in the international world, but I'm sure, Denise, you can really speak to that as well.
Yes, I think there is a huge opportunity for an exchange that happens both ways, bidirectional consultation and support. I think the expatriate MPH prepared consultants that I've worked with in the past have had preparation that's all over the place, all sorts of different backgrounds in terms of what's going to happen in that 1 or 2 weeks of consultation, or 3 months or 12 months. Quite often, I think there isn't a standard. That was something that the London School of, is it Tropical Medicine and Hygiene? When I was in Geneva, I was with one of the educators there who said that she had received a lot of concerns from international or different governments saying that maybe there could be a program that would prepare MPH prepared students to be consultants in terms of what to deliver for individual countries. So I see that as an opportunity for the program, for the school, is to have a course that prepares you for the consultation right down to the toolkit. Very practical. And I have to apologize, I am quite practical. And I think, too, in terms of the cultural competency that's needed for the consultant that is coming to the country, that's incorporated into the plan, I guess.
Only quick comment I would have, because certainly my international work's been very limited to the work I've been doing in Bhutan and so forth, and it's been with people from a mix of different, developed as well as developing. I would not say they're developed and developing nations. It's been a unique experience in that most of the people who have come from the developed countries involved in this, whether it's Canada or the UK or France or Switzerland, it's been a learning experience for us, because what Bhutan and their notion of gross national happiness has provided is a whole different perspective on what progress is and what positive change is. And we've brought skills in terms of helping them measure it and do that kind of stuff. But from a content point of view, it's mainly been a learning experience. And that's why they'll have an international conference in Bhutan or Thailand or anywhere else, and they get 600 people coming from literally all over the world because of their interest in their concept. So my experience in global health has been quite different, in that it's been, I've taken skills in terms of this is how you design a survey, this is how you analyze data, et cetera, but in terms of the concept, what we're measuring, the learning has all been coming this way in terms of from them to me.
Yeah, I think it's a good question, and I don't really have much of an answer to it. I've done a little bit I'm interested in Trevor's response to it, actually. I've been involved in consultations in different countries off and on, kind of as the technical consultant, and I think we got a long ways to go to be able to really do what Mike has described as a true partnership. I mean, Trevor and I have been involved with one in Brazil, which I think has been a true partnership, exchange of knowledge. But there still is a bit of this attitude that we go in and we're going to help them become like us. And, a terrible attitude to go in with. The cultural competency situation is bad just in itself, but the lack of being able to take those opportunities for us to learn and build internally. So I don't know what the career opportunities are like. I know I am an adjunct faculty with SFU, and they have a global stream in their master's program, and students seem to get practicums and get out there and are working in the field. But I would hope that the program would really understand that the key, from my point of view, the key to global work is the relationship, and to build the ongoing sustainable relationships with people is critical to make it effective. Trevor, I don't know if you want to comment, because you've done a lot.
No, I completely agree. You know, if you go to Brazil, for example, as I've done to work on healthy cities, you're going there to learn as much as you're going there to teach. It's a two-way stream, because Brazil is where participatory budgeting comes from. Brazil is where Paulo Freire comes from. Brazil does all sorts of wonderful things in its cities. I've been to cities there, and it just blows you away what they're doing. And you come back saying, how do we do that? I wish we could do that. How can we take that and adapt it to here? So it's very much an equal partnership going into those sort of situations. I guess the other thing is the reference was made to cultural competency, to not going in with the sense that we're the experts, we have the right values, but to also understand that there are things that we do here in Canada that is very hard to do elsewhere. I mean, one of the things I talk about when I talk with people doing community development is tough to do in Canada, but in certain parts of the world it can get you killed. So you need to understand that the people you're working with are working in very, very different situations, where things that we would simply accept as okay, I mean, kind of tough and a bit edgy and provocative and so on, in some parts of the world they are considered a threat that is met with violence. So you can't expect people in those situations to be able to do the things that we feel able to do or feel they ought to be doing, and you also are breathtaken by how often they still do it anyway. It's quite astounding. We have time, I think, for probably one more question. So who wants to? Okay.
Thank you. Thanks. I want to say thank you to all the panels. My question is, I have two questions, if that's okay. And it's directed towards Denise, the first one. First of all, I was very inspired by your presentation, having been to Lesotho and also to Swaziland, and having visited the Clinton Center myself when it was just put up. So I'm really glad to hear the work that has gone on there, because when it went up and I was visiting, I said, I wonder what will become of this. Is this just, or in North America, going in to, remedy these poor Africans? So I'm really glad to hear firsthand of the work that went on. The question I wanted to ask you specifically is, how has the skills that you acquired in Africa, in these two places, in your work, assisted you in the transition to your work in First Nations communities? And do you see common health inequalities, and what sort of response you have to those, and what would you do differently?
Wow.
So that was kind of one question.
Okay, in 2 minutes we'll go.
Yeah, my other question for the whole panel is, in your current capacity, given your experiences throughout your career, if you were called upon right now in our current healthcare climate to give an advice to the Minister of Health or to the Deputy Minister, what directions, what two key pieces of advice would you offer to the Minister in terms of the direction that public health should take in helping to improve the health of our nation?
Thank you very much for your question. I would say some of the lessons learned would be learning the cultural competencies immediately rather than being key to implement. The commonalities with First Nations communities and other Indigenous communities has to do with access and equal distribution. I would say that in BC, First Nations primary healthcare providers are nurses, very similar to what's happening in Africa. The policies are different. Nurses are initiating and managing antiretroviral therapy in Africa, in sub-Saharan Africa, and it is something that is, it's very protocol-based, similar to what we have with the new certified practice through the CRMBC. So I think there's room to identify the new roles for nurses who are screening and referring their clients in collaboration with their public health nurses. What else do we have here? Commonalities. I would say the access issues really, it's one of the things that we're really working on, to be invited to the table so that nurses, their role is recognized, and that we're able to build better partnerships across the 203 communities that nurses are serving. And then the third part of the question, I forget. Can you remind me? And I'm fading here. I would, well, one of the key things I did was to work with healthcare providers initially before taking on any role. So if there wasn't a champion within the Department of Health, I wouldn't take on the consultation because it wouldn't make sense for the exit strategy. So I wish I would have taken that on earlier. That was a key lesson learned, to always be working through somebody so that you had a key exit strategy. And then also to build capacity with the chief nursing officers. Quite often in most of the ministries, the nursing officers were acting, and they were acting for many years. So they were in positions where they weren't able to implement policy. And so I would have worked more to build capacity with the chief nursing officers that I had the opportunity to work with. And then understanding the competencies. I just think in terms of the cultural competencies and the communication, I had no idea my colleagues were offending so many of their counterparts because they didn't say hello in the morning. They were focused on the tasks, and everybody just stopped. And so when I learned that as a Canadian working among Americans in a South African context, it was such an eye-opener, and I feel one day I may do a PhD and write about it. There's a lot of information, but just in terms of what you can get done, I think, in a 10-minute coffee, you can get so much done because you cared to take the time out with your colleagues, and then the work gets done. So it's that respect. So I wish I did more 10-minute coffees with my health leaders that I've worked with. And then now applying that here, I'm building relationships like crazy. Thanks.
And I want to hear Ted and Joan's answer to your second question, so I'm just going to pass it on.
Ted, you first.
Well, first of all, you'd make a good minister of health yourself, because that's usually the question you get. Give me the one thing that's going to fix it and I'm going to do it, right? And they're dreaming because you're not going to get the one thing. But two things, I guess. One is because I don't think we should be pouring a whole bunch more money into medical care, I'd say tell the medical establishment that any money they're going to get for medical care in the coming year has to come out of them ending unnecessary and harmful procedures that they currently do. And then the second thing I would tell the minister is he needs to advocate within his cabinet and with his cabinet colleagues for a comprehensive poverty reduction strategy for the province.
Almost ditto. The second ditto. Yes, addressing inequities, and I don't think that that's just a Minister of Health responsibility. That should be directed to the Premier. So looking at inequities and a definite poverty strategy.
I agree completely with Ted.
Joan.
Well, I don't disagree with Ted, or don't disagree with Joan, but yeah, I love Ted's answer.
We just know how hard it is to work with doctors.
I would add to it, I would change the way we pay physicians. That's the number one thing I would do.
That could be third.
Okay, that's number 3.
Okay, well, thank you, all of you, very much. You've been very generous with your time. You've informed us, you've entertained us.